two very timely presentations today on sort of relatively different ends of the spectrum of important topics in cancer, and I personally am looking forward to both. Our first speaker is Dr. Valentina Greco, who is an associate professor of genetics, dermatology, and cell biology. Valentina received her undergraduate degree at the University of Palermo, her PhD at the Max Planck Institute of Molecular Cell Biology and Genetics in Germany, and did her postdoctoral training at Rockefeller University with Elaine Fuchs. No relation, at least that I'm aware of. Her lab has really been doing extraordinarily seminal work in cancer biology and understanding how cells deal with in the early stages of neoplasia. And she really has championed a very novel approach of intravital monitoring or assessing of cancer cells that obviously you'll hear about. And I'd be remiss in not pointing out that she was also the recipient of this year's Class of 1961 award for her exceptional work in cancer research. So Valentina, thank you for talking with us.
Hi everyone, I'm very excited to be here, and I'll welcome any questions throughout the presentation so that we can be more over time.
Can people hear her?
Can you hear me in the back? Thank you. In my lab we use this sentence and these statistics to reflect upon the large amount of cells that we make and lose every day. And what is astonishing for us is this happens at the level both of the tissue as well as the cell, where this balance between growth and regression has to be constantly equilibrated at the level of the tissue, but as well as the level of stem cells, which are these cells within all your tissue that have to decide whether they can amplify their pool and therefore create more of themselves, as well as deplete the pool by differentiated or apoptosis. And what we are fascinated is by the fact that this has to happen in the presence of constant demands for regeneration in tissue like your skin, your gut, or your blood. And in particular, my lab is fascinated by trying to understand this homeostatic equilibrium and these edges. So how flexible this process is by tinkering on each side, either by using growth mutation that can allow us to explore that side of the growth, as well as through the regression side with tissue loss and injury. And so when we started 8 years ago, we turned to skin because of its unique accessibility, and because there are decades of work from giants in my field, like Elaine Fuchs, Fiona Watt, George Cottarellis, and many others, that have defined the epithelium within the skin as two very neat contrasting comparing models. One is the epidermis, which is what you touch when you touch your skin, they continuously regenerate. So every time stem cells are always at work making more of losing from your skin. The other is the hair follicle. Your hair are under a temporal regulation, which means your stem cell oscillate between quiescence and activation state. And so by using these two systems, in collaboration with Ann Aberman, who is the director here of the intravital imaging facility, and Dave Gonzalez, we team up to set up a system where we can image these mice in an injured state, so they are simply on a heated plate. And this was the work of Adelis Roncolas, one of my first postdocs, who has now his own lab at UPenn. And what Adelis did is being able to capture in a live mice a principle of regeneration, where you can capture, for instance, proliferation as well as migration in an undisturbed system. And so through these movies and time lapse of this kind, what we have been able to do is to ask fundamental questions of how tissue maintain that homeostatic equilibrium, as well as start to capture the emergence of pathology from normal tissue growth. And so through this process, some of the advances that my lab has been publishing have been recognizing at the tissue level that depending where your cells are, that dictates what they do. So they are in an environment that is defined as niche, which means they're neighbors as well as extracellular matrix. And depending on their position, they have a different fate, as well as this position, the niche itself, can be sufficient to control and restore the stem cell pool within your tissue. At the cellular level, it has allowed us also to discover things that we could not even have predicted. For instance, we discovered that epithelial stem cells eat each other. And so we captured these through the imaging without any prediction of that, as well as understand that the stem cells can be dispensable because other cells can change their fate and replace them, which changes the perspective we have in the regeneration field, which is all stem cell centric. Okay, so considering these homeostatic advances, well, I was telling you my lab is interested in understanding from the tissue growth perspective what are the edges of this process. And so it rests on an incredible discovery that we and our tissue are full of mutation in steady state. So if you take this as a simplified version of a tissue, each of the cells may be a mosaic of mutation, and some of which are even oncogenic. And so it really raises the question why we don't develop cancer sooner. And it lets us to ask how does a normal tissue cope with mutant cells. So in order to start to address this question, we started with a single mutational approach and had to develop a system where we can go back to the same tissue, the same follicular structure, the same cells over time. What you're seeing here is a large field of view in the ear of a mouse. And what you're seeing here, all these segments are follicles. You can zoom in and have a cellular resolution where not only you can see all epithelial cells through the marking of the nuclei, but you can also mark or even genetically modify a subset of these cells here in red. And then ask how this mutation is impacting the physiology of that tissue over time in the same mass. And so the first choice we decided to go in terms of mutation was activated beta-catenin. It is a benign mutation in the skin in the sense that it is linked to tumors that are not malignant. They are called pilomatricoma. But it was a very well-characterized mutation that was established by Len Fuchs and Fiona Watt in the past. So what two of my former trainees in the lab, one is Peggy Neal, who has her own lab here at Pathology and Dermatology, and Elizabeth Deschênes, team up is to understand how these beta-catenin mutant cells act within our tissue. And what you are seeing here is a time lapse that shows a follicle here where all the epithelial cells are green, and the mutant cells are roughly in red. I'm saying roughly because it's just a reporter of the activation system we use and not of the mutation itself. But what they discover is that this hunchback, which is the initiation of a growth that then will enlarge, are made of actual mutant and wild-type cells. So when in the past we have understood the outgrowth composition, aberrant composition of growth, made of either cells that carry several mutations or cells that carry different mutations that cooperate in making the aberrant growth, what we understood here is that there is a mix of both mutant and wild-type cells, which at the time we interpreted as mutant cells are corrupting the wild-type cells to cooperate in making this growth. So that work led to a follow-up where Samara and Christy, two very talented students, team up to understand what are the consequences of these mutant cells over time, if we can do longitudinal studies and understand how the tissue deals with these cells. And this is in collaboration with Bobby Baronte de Fredhouse and Katie Swarty, who is now a faculty at Yale. So what Samara and Christy did is, again, taking several snapshots of the tissue in a live mouse and then inducing the mutation and inducing this growth that we knew would be formed. But what was very surprising is that as they follow them over time, they noticed this growth being shrinking, and then after a few weeks of being gone. And even when they revisited this follicle, they didn't see any sign of reemergence of this growth. This was totally unexpected and really spoke to a plasticity within the skin epithelium that we had not anticipated. Even further, when Samara and Christy decided to increase the dose of the number of beta-catenin mutant cells within the tissue, what they discovered is that this correction cannot still occur. So if you're seeing here again a field of view, a zoom-out view where all these segments are follicles, and if you look at them in a 3D reorganization, you can appreciate that they have some sort of an architecture that is regular with these glands and the follicular structure here. When they express a large amount of beta-catenin mutant cells, the whole landscape completely changed. You appreciate here that there are this deformed growth. And just in few months, what Samara and Christy saw is the all same region and throughout the skin of the mouse. The structure could be reabsorbed, normal architecture would be reestablished, and the function of this follicular structure continued. So this was very exciting to us because it showed an ability of the epithelium to deal with the sensing and correcting aberrant structure. But I left the question of whether it was due to beta-catenin mutation specific ability or whether it could be seen with other mutations. And so Christy decided to use an oncogenic mutation, Hras Giv, And I'm just showing you a large view of a growth. You're looking top down on the ear of the mouse. And these circles are the entry point of follicles. So you're looking at a much zoom out view than what I showed you before. And this is a papilloma, which you can see an XZ view as well as an XY view. But when Chrissy tracked over time, she saw reabsorbing so much that you could see all the entry of the follicle now re-emerging in this XY view. And therefore showing the power of correction that is happening not only with the beta-catenin system, but also with the Hrass system. So in a nutshell, what I told you this part, and I want to just move on to ongoing and published data, is that we had to rethink the way we think about these homeostatic equilibriums. We thought that in general it had to be kept under control, whereas it looks like it could be much more flexible, where the amplitude of this growth can be much higher than anticipated. And for data I haven't shown you, the new steady state can even be reached and maintained over time. And so we saw that the skin tissue, the epithelium is capable of recognizing and eliminating beta-catenin mutant growth. The same is true for a Hrass mutation. And we saw a very interesting phenomenon where in this correction, some cells were left over, and those who were wild-type cells, new hair follicles were made that they were absolutely normal at factorial. And so that will lead to other investigation in the lab. And so the next set of questions that were arising from these discoveries were, first of all, what is the fate of the mutant cells? And so in the work that we just published, what Samir and Christy saw is that in the beta-catenin model, very intriguingly, not only the mutant cells are eliminated, but also the wild-type cells have an active role in eliminating them. And they show that through a number of genetic approaches that I'm happy to share later on. In the case of the Hrass model, we remain without an answer of what was the fate of the Hrass mutant cells. And so what Christy did is to take an approach where she could revisit the same follicles over time. In this case, is an example of a representative sample of a wild-type follicle in green, where the mutant cells here are in red. And she can revisit these same follicles across several mice and see how the mutant cells or the wild-type cells are doing. Here in red, you're seeing the wild-type cells, and you can see that the proportion of red to green is more or less the same after 3 weeks of this follicle growing and shrinking. In contrast, when she looked at Hrass mice, you can appreciate that the red to green ratio is much more altered, and I'm just telling you the quantification, but what we see is that the mutant cells are capable of taking over at the expense of the wild-type cells. So very different scenario from the one of the beta-catenin. Further, Chrissy was very interested in understanding whether this signaling was active since they were taking over. And so she looked at even all tissue of the skin, which the mutant cells represent a small proportion, and it was so capable of seeing the activation of this pathway that really shows how these cells not only are integrated and expanding, but even utilize 2 branches downstream of Hrass of activation for this signal. And so altogether, what Chris is seeing is that in contrast to the beta-catenin model where the cells are eliminated, in the Hrass model, they are integrated, they expand, and the signal is even active. And so the first point that this is allowing us to make is that while tissue correction seems to be conserved across different mutational models, at the cellular level, this can be executed in different ways. The other question that it really raises for us is understanding the phenotypic consequences of these integrated and expanding mutant cells. And Christy bumped into an observation that we didn't know, couldn't predict, which is depending on the niches in which Hrass mutant cells were expressed, we saw different phenotypes. And so up here is the epidermis, down below is the hair follicle. You can use different drivers to drive this oncogenic mutation in different compartments. And what she saw is that when she used primarily epidermally expressed drivers, that she could have in few months development of masses and then later on actual malignant cancers. But when she expressed this mutant oncogenic form in the hair follicle, she saw that the structure and the function of the tissue was much more preserved, and it lasted up until even a year and more. So this really sets apart the compartment within the skin epithelium and reveals a level of tolerance that is almost phenotypic in the case of the hair follicle. So Christy was very intrigued in understanding what principle is the hair follicle using in order to tolerate these mutant cells. And so what she did is thinking that perhaps she could use the hair follicle regeneration cycle and the state to look at the regeneration ability of this Hrass model. And And so just to bring you up to speed with the hair follicle, it oscillates between the rest and the growth phase. And the rest phase is usually, depending on when you look at, even 3 to 4 weeks long. And so this regenerative cycle is also mediated from the cooperation between the epithelium in green and the mesenchymal cells that are around in red. And what Christy wanted to understand is how does follicle tolerate Hras G12D by asking two different questions. One is looking at these follicles during the regeneration cycle and ask whether she would observe any phenotype. And second is using approaches we have in the lab to test the regenerative potential. So when Christy looked at the hair cycle, she saw that when she looks at wild-type follicle in the rest phase, as predicted, they will remain this short stunted follicle because they are still in the rest phase for several weeks. In contrast, when she sees the Hras follicle, you might appreciate that they go from being short to much longer. That means that they entry sooner in the growth phase, and they are in fact showing to be continuously regenerated. So Hras follicles doesn't seem to rest, and it seems to continuously regenerate. So Christy wanted to ask if in an assay that we have previously established in the lab that tests further the regenerative ability of the follicle, if we ablate this portion of the follicle, what would happen in a Hras context? And what she saw is that while in contrast to the wild-type follicle, where you can laser ablate with the same microscope that we use to image specific compartment within the follicle and see that there is recovery, but the follicles are slow in growing again and becoming long. In contrast, the Hras, they shrink, but they continue to grow. So this shows that they have this ability to regenerate, which is also added to data I have not time to show you, where the mesenchyme is also much more active than we had anticipated. So these two pieces of data tells you that this follicle continuously regenerate, and also they regenerate faster even upon insult like this laser ablation assay. And data I have no time to show you also show that the profile of the mesenchyme by both staining as well as qRT-PCR show a profile of proliferative mesenchyme, which normally is quiescent, as well as new markers that are embryonic markers. So it seems therefore from this data that Hras epithelium is cooperating with the mesenchyme in order to drive continuous regeneration, which may be the way that this tolerance is occurring, and therefore oncogenic mutant cells are buffered. So Christy wanted to understand how this crosstalk was mediated, and she was interested in a molecular link. And so she designed, together with the Cytoplex core facility here in Paula, an unbiased screen where she wanted to ask first in vitro and then in vivo whether the Hras epithelium in the presence of mesenchyme would release different cytokines than when it was the normal wild type with the normal fibroblast. And so what she did is run this assay with the Cytoplex and notice that out of 28 cytokines targeted, there was only one that was standing out to be differentially expressed when the Hras epithelium was cultured with fibroblasts and compared to the wild-type epithelium cultured with fibroblasts. This is a GCSF, which was very interesting to us because a lot of cancer cell lines have been also associated in squamous cell carcinoma, for instance, to be associated with the GCSF increased expression. And when she went in vivo, she saw that both the protein level of GCSF by Western blot as well as downstream target genes were in fact upregulated in the skin. So this says that from in vitro to in vivo, we have a candidate that may have a role in the Hras mediated regeneration. And so this is the last piece of data I want to share with you. Christy wanted them to ask whether GCSF impact, in fact, this Hras regeneration in vivo. And the way she was thinking about is using this assay that I show you. By laser ablation, you can trigger this regenerative potential or harness it. And then in the presence of this antibody against GCSF, ask whether or not we would have an impact or whether perhaps we would stall regeneration, getting at the molecular link that allows this Hras epithelium to be so highly regenerative. And so what Christy did is exactly the same assay. She ablates a follicle when it's treated with the RGG and see that they can grow. But then when she treats it with the anti-GCSF, to our surprise, what we see is that while the follicle is trying to recover, it starts to become aberrantly growing with an organization that is reminiscent to benign tumors that we are currently monitoring. And so this is very exciting to us because it's unexpected, as we were thinking that it would actually mediate a benign regeneration. And what it seems here is that this may be a molecular link, perhaps, that can mediate keeping under control Hras oncogenic potential. And so there are lots of questions that are remaining for us to look at, including whether GCSF effect may be specific to Hras, also working in normal homeostatic regeneration, is known its role during repair, for instance, and also being much more careful about the cellular and molecular impact that this treatment is having on the mesenchyme to really understand this equilibrium of epithelial-mesenchymal interaction in the Hras regenerative phenotype. And so with that, I'd like to conclude by telling you that we are interested in understanding this mechanism of tolerance. We have seen that there is a dynamic component to it, where growth can be made, sentinel, corrected, and go back to normal. But there is also a much more controlled system we are seeing with Hras, where the phenotype are subtle, and they are just a much more enhanced regeneration. And what we have shown you is that in the case of mutant Hras, the cells can integrate and expand and have even an active signaling, and yet not showing any phenotype. Hras epithelium seems to non-autonomously act on the surrounding mesenchyme, and GCSF may be a mechanism by which this epithelial-mesenchymal crosstalk is designed in order to buffer the oncogenic potential. And with that, I'd like just to leave you with our own ideas that we think that the imaging can be a very powerful approach in combination with others to understand mechanism of tissue regeneration, as well as try to understand this interface from normal tissue with mutated cells and go into the homeostatic breakpoint that leads to cancer. And I'll leave you with a picture of the lab, the last murder mystery game, with great collaborators of Christine Cohen, Donna-Ann, founding and former lab. Thank you.
So questions, Valentina. I'll take liberty starting. So I'm curious, because when I think about mutational spectra for skin cancers in humans, you know, the hedgehog pathway is certainly a very common driver event. Is that something you can study in your model?
Yeah, Peggy Mung actually set up this system. She's very interested in basal cell carcinoma, and she's looking at a mutation in patch and sonic hedgehog pathway, absolutely.
And any observations as of yet?
She has a very cool ideas and data supporting the idea that the stroma has a repressive potential towards cancer. And I'm sure if you invite her here, she will tell you more.
Okay. Other questions?
The expansion of Hras cells is due to an increased follicular rate or inhibition of the wild type cell growth rate?
Yeah, thanks for the question. We think both. I haven't shown you the data, but we seem to see that wild type cells have a lower rate of proliferation, and we have to determine whether they have a higher rate of differentiation that might also push the balance towards that. But Hras definitely have a rate of 1.1% increase every week that we can observe. And there was some statistic we were hearing about other mutations having a very similar rate of expansion. So it might speak about the homeostatic control per se, rather than again a mutation-induced ability to overcome.
So in the classic skin carcinogenesis model, Alan made decades ago that Hras was very common, that's what he said. And I'm wondering since then, though, whether analysis of that system has shed any light on what kinds of factors restrain Hras tumors and that develop in those HRAS carcinomas.
Yeah, no, it's a great question. I think, first of all, those data are classic, and we also know that you can do, for instance, EMBA, which is a carcinogenic inducer, and then leave the mice for a year before you apply EPA.
Those are the ones.
And so clearly you can buffer and tolerate this mutation for a long time. I don't know that we understand yet about restraint, and one hypothesis is that it was very difficult to study the rest of the skin up until now. What we can study very well, I think, is tumors and their architecture. And so I don't know from Anand that we understand that much, except that there is a paper that we were thinking that the heterogeneity level with respect to papilloma and stomach carcinoma may speak to the ability to be more aggressive versus be restrained. But in terms of factors and in terms of mechanism, homeostatic mechanism, I don't know that we understand yet.
Yes, modifiers.
Say it again?
Yes, modifiers to genetic.
As modifiers. Absolutely.
Well, Valentina, thank you for an excellent
you.
talk. So while we set up, our next speaker is Dr. Donna-Ann Thomas. As many of you know, Donna-Ann is Assistant Professor of Anesthesiology and Chief of the Pain Service at Smilow Cancer Hospital. Clearly a critical issue in both cancer care and clinical cancer research. She is a graduate of SUNY Upstate and the training program at SUNY Syracuse. And her topic today are advances in pain management for cancer patients. Thank you.
Thank you. Good afternoon. Thank you for having me. So I just want to make sure you can all hear me back there. So I'm going to be talking about some advances and some of the approaches to cancer pain. I have no disclosure. So what I want to talk about is take an overview of considerations in cancer pain, and focus a little bit on breast cancer in my overview. And then I want to look at the complex interplay of pain management and cancer progression in cancer survivors and clinical implication that we're now seeing both in humans and in animal models, and then discuss a little bit or a brief overview of some of the advanced interventional strategies that are used for cancer pain patients. That's okay, I'll use my computer. Oh, that's okay. Okay, that's okay. So unique considerations in pain medicine. So more and more patients are surviving cancer, and the diagnosis of cancer has significantly increased over the last several years. In 2017, there were over 1.6 million new cancer diagnosed, and over 600,000 patients have died in 2017 due to cancer. A new report by the American Cancer Society in collaboration with the National Cancer Institute estimates that approximately 14.5 million survivors of cancer are alive in the United States today. And that number is growing, and it's estimated that it will be almost 19 million by the year 2024. So why is that very concerning? Well, the good news is that more and more treatments are leading to better survival. But the bad news is that more and more patients are getting persistent pain syndromes. And this is due to, in some point, to the cancer itself, also to the treatment that for the cancer. So there are about 30 to 55% of patients who are diagnosed with cancer who are undergoing treatment for their cancer. And of that, nearly 80 to 90% of those patients with advanced disease suffer some moderate to severe type of pain. In breast cancer, the prevalence in 2016 was about 240,000 in terms of new diagnosis. And the 5-year survival of those patients was about 90%, so 90% of those undergoing treatment. In 2013, they estimated that there are over 3 million patients living with breast cancer in the United States. Chronic pain, however, is one of the biggest impact of these patients, and it's been shown to affect their quality of life. And it affects about 25 to 60% of breast cancer survivors, and this can persist up to 10 years following treatment. It can be during treatment or after treatment, and even though some breast cancer patients have pain that are unrelated to cancer, it does have an impact in the lives of many of the breast cancer patients. Pain is one of the most distressing symptoms reported by many of the breast cancer survivors, and it is a symptom that is most feared by many of their patients and the families. Pain is associated with impaired quality of life, significant disability, and most alarmingly shorter survival time in these patients. And satisfactory pain treatment is one of the most important things for these patients. They want to make sure that having survived the cancer itself, they can have a better quality of life because they don't have to live with chronic pain. In most instances, patients with cancer or diagnosis of cancer have chronic pain because of the tumor involvement. This occurs in about 78% of those patients. There are some patients who have pain associated with the cancer therapy, and some patients, as mentioned before, have pain that is unrelated to cancer therapy. And then the patients who are dying with cancer typically have generalized pain. In breast cancer, however, there is a difference and some unique considerations. Because there are so many patients who have survived breast cancer treatment, and about 90% of those under treatment have survived it. The major cause of pain in those patients are due to the treatment for breast cancer. Pre-treatment risks for these patients include prior pain conditions, psychosocial aspects, age, genetic risk factors, and the impact that our treatment have in terms of pain, in that surgery can lead to post-surgical pain, post-mastectomy pain, lymphedema-related pain. Chemotherapy can result in peripheral neuropathy in these patients. Radiation can cause burn injury and radiation neuropathies. And hormonal therapies have been linked with arthralgias on these patients. So the therapy that we use, even though very effective for the treatment of breast cancer, have been linked to chronic pain in these patients. In addition to other therapies, I need to mention also that their patients can develop neuropathic pain syndromes, and many patients who undergo surgical therapy can develop these neuropathic pain syndromes, such as post-amputation limb pain, post-thoracotomy pain, post-mastectomy pain, plexopathies, both brachioplexial and lumbar, and pain due to celiac infiltration. So we see that having survived cancer, that unfortunately many patients have to, lived with pain, and our goal is to manage those patients' pain so that they can get quality of life. However, there are certain considerations that we have to take in our treatment of cancer, and one of those is the studies that are coming out regarding SSRIs. There are patients who live with pain and have underlying depressions, or live with pain, and many of those pain neuropathic. One of the approach that we have for the treatment of neuropathic pain can be the use of SSRIs. And what we're seeing is that SSRIs, especially used to treat patients with cancer pain, and specifically patients who are on a tamoxifen treatment, can actually affect survival time on these patients, and can also lead to the tumor further metastasizing. Tamoxifen is converted to endoxifen by the cytochrome P450, specifically CYP2D6, and the conversion is affected by the genotype. It is SSRIs are potent inhibitors of these CYP2D6, and it reduces the bioavailability of the endoxifen. So drugs like Prozac, Cymbalta, Wellbutrin, and Paxil have very strong inhibitory effect on CYP2D6, and other drugs like Zoloft and Celexa has a moderate inhibitory effect. Drugs like Cymbalta are routinely used for neuropathic pain in our world. So we have to be careful, and when we are treating patients with neuropathic pain, that we take into consideration this information and this research. There are also studies that are being done in animal models, including rats, that have looked at morphine and its effect on tumor progression and tumor growth. And the studies have shown that morphine does not affect tumor development, but it does promote the growth of the tumor and does lead to tumor metastasis and therefore decrease survival time. And while this is in our rat models, further studies do need to happen in terms of humans, and we have to take these into consideration when we're treating patients. Tricyclic antidepressants such as amitriptyline and nortriptyline have been shown to also increase risk of metastasis and decrease survival rate on patients. And so that's another drug category that we as pain physicians have to take into consideration when being used to treat neuropathic pain, especially on patients with breast cancer. So what I want to move on to is I want to discuss some of the advanced interventional strategies that we use and can be used to treat patients with pain. Common concerns with patients with cancer pain are, should we put the patients through procedures? There are concerns because we have to put a sick patient, we have to get them into the correct positioning for a patient. Some patients have anticoagulation concerns, and we have to weigh the risk and benefits of whether we should get these patients off anticoagulations in order to do procedures, and the risk that would be involved with reversing the anticoagulation of these patients. Many of these patients are immunosuppressed. The question is the patient too sick for procedures, or is it too early for us to consider procedures on these patients? And then the other thing is access to follow-up with interventionalists, because some of these patients are homebound. It's difficult to get them in for a doctor's appointment, especially for routine follow-up visits or for repeat procedures. So these are things we typically have to consider when we are considering doing procedures on patients. Many of the procedures that we do on patients include blocks to joints, blocks to extremities, nerve blocks, including median branch blocks for facet pain. But the more advanced blocks that we typically do, one of those is neurolytic block. And what a neurolytic block is the use of alcohol or phenol for chemical neurolysis. There can be a surgical neurolysis by simply cutting the nerve. We can use heat as a form of neurolysis with radiofrequency ablation, and we can use cold as a form of temporary neurolysis with cryoablation. Of these, we have available here at Yale radiofrequency ablation. We're working on getting cryoablation and neurolytic or chemoablation. So there are two types of ablation. One can be peripheral and one can be autonomic. Peripheral involves nerves like the intercostal nerve, and it's typically for patients who have intercostal neuralgia, where a diagnostic block is done on the patient initially, and the patient has a good response from the diagnostic block, and then a neurolytic block can be done on the patient. For autonomic blocks, the cilia plexus block or superior hypergastric plexus blocks are examples of autonomic blocks that we can use for pain. So the advantage of the neurolytic block is that the neurolytic effect typically lasts about 3 to 6 months. In some patients, we can get it lasting a year, but on average, it's about 3 to 6 months. And the effect does fade because of either progression of the tumor or nerve regeneration. One of the things that I should mention when we use alcohol for neurolytic block is that alcohol is excruciatingly painful. So when the patient has that, a lot of education is required before we do that procedure to let the patient know that the first 24 to 48 hours can be extremely uncomfortable, and there's a planning that goes in place for those patients, which may include temporarily increasing their medications in order to get them through that period. But once the neurolysis completely occurs, then the patient will have a significant decrease in pain. and that decrease in pain has been shown to also decrease the patient's opioid requirement. So I just want to take a look on many of the anatomic blocks that we do. The celiac plexus blockade, the indication is typically patients with pancreatic cancer, distal esophagus and transverse colon pain due to cancer, pain from the liver, adrenals, kidney, proximal ureter, and mesentery. And that block is targeted at L2, where the celiac plexus is located right in front of the aorta, and there are multiple approaches that can be used in order to approach the celiac plexus. When we're doing a neurolytic block, we try to be as precise as possible. So a CT guidance that you see there is typically as precise, and also fluoroscopy guidance can be used to do the neurolytic block. A meta-analysis of greater than 1,100 patients, 63% of which had pancreatic cancer, 37% had other intra-abdominal cancers, showed a 96% rate of the celiac plexus block with complete or partial relief in the pain in about 3 months for those patients. When the study went further, about 70 to 90% of patients still continued to have relief greater than 3 months after the neurolytic block, even up until their time of death. So this has been shown to be very successful. And the block does have some adverse side effects. It does have some adverse side effects, the most common of which is transient local pain in the site of which we do the block. Transient hypertension, because the celiac plexus block is a sympathetic block with an overriding parasympathetic after the block is done, and this can also result in transient diarrhea. Most commonly, the diarrhea can be treated with medications, and it's very rare that patients have continuous diarrhea following this procedure, although I do know of one case that occurred that the patient had unrelenting diarrhea following this procedure. The superior hypergastric block, the target of the superior hypergastric plexus is at L5, and this can be used for patients with pain resulting from cancer from the colon to the rectum, bladder, prostate, gonads, ureter, vaginal fundus, and some inputs to the perineum or anus, and then lower abdominal and pelvis. Studies have shown that this diagnostic block is very successful in patients, with about 70% of patients responding, and then patients undergoing neurolysis or neurolytic blocks of the superior hypergastric plexus, about 51% reported pain less than 4 out of 10, and sometimes the block had to be repeated for a better effect. But this has been shown to decrease opioid consumption in patients, and typically patients don't require additional blocks for up to 3 to 6 months. However, if a patient has extensive retroperitoneal disease, the results of this block is less, significant less. And in some cases, very uncommon, but in some cases, multiple plexus blocks have been needed in patients because of their tumor growth and tumor expansion, and that usually are a combination of celiac plexus, superior hypergastric plexus blocks, superior hypergastric plexus blocks, and inferior plexus blocks on patients. And then the next block that I wanted to discuss is our ganglion impar block, and this is a block that is done right at a sacrococcygeal ligament or junction. It can lead to neurolysis or cryoablation of these patients, and it's typically used for patients with perineum, distal rectus, anal pain, and distal urethral pain, pain to the distal 1/3 of the vagina or vulva. This is one of the blocks that we have commonly used. It does have very, very little side effects, and no complications have been reported in the literature regarding this block. It has been shown to be very efficacious in these instances. And then finally, I wanted to take some time to discuss spinal drug delivery systems, of which we have now implanted 3 since started Cancer Pain, and we're in the process of moving on with that program, and hopefully we'll be able to implant more of these patients. The indications are typically patients with unacceptable side effects from medical management or uncontrolled pain with medical management. Typically patients are given a trial, and the trial can be either a single bolus or it can be a continuous infusion, and if it's a continuous infusion, that infusion is done in-house. Contraindications include active infection and tumor involvement, tumors obstructing CSF flow, or any mechanical barriers. Typically, the life expectancy in order to place this device typically has to be greater than 3 months for patient survival. And we take that into consideration because when we consider an end of life, typically patients are more likely to develop seromas, more likely to develop complications, and more likely to reject device. Complications include catheter-tip granulomas, seromas, infection, catheter dislodgement, mechanical failure, CSF leak, and catheter kinking. Catheter dislodgement does occur very frequently, and we had one case here from an outside pain physician of a patient who was here about 2 or 3 weeks ago. So that can happen, and it's imperative that we recognize the sign of overdose. In many cases, patients have a sober partner when they have an intrathecal pump, and they're counseled with the use of naloxone and when to bring the patients in and what signs and symptoms that we're looking for in these patients. Side effects from the catheter and the intrathecal infusion can include lower extremity edema, urinary retention, pruritus, myoclonic activity, and sweating, of which I've seen all of these side effects on patient. Most commonly, urinary retention is one of the most common ones that I've seen. Sorry. There are 2 types of pumps. There's an external pump and an internal pump. The external pump is typically placed with patients with a lower life expectancy than the internal pump. The internal pump does have its advantages in that it has a decreased risk of infection. It is fully independent of external devices, therefore you don't have to access this pump, and the life maintenance is really small because it's infrequently refilled. The battery life lasts about 10 years on many of these pumps on average. The external pump has to be accessed weekly, and it's usually hooked up to an infusion device and changed, and we only consider those on patients that we know really need the technique, so they would definitely benefit from intrathecal technique, but their life expectancy is so poor that we know that it's not worth the risk of placing the internal device. Common intrathecal drugs are morphine, hydromorphone, ziconotide, clonidine, baclofen, fentanyl, bupivacaine. There are some pain providers that also use ketamine in the intrathecal pump. But these are the most common ones that are used. And there's significant evidence that compares comprehensive medical management to intrathecal device, and shows that intrathecal device not only improve clinically pain in patients, it reduces pain, it significantly reduces drug toxicity. because the intrathecal ratio is typically 1 milligram intrathecal morphine is about equivalent to about 300 milligrams of oral morphine. So therefore, the patient would have the analgesic effect of the morphine with a smaller or significantly less side effect profile. And patients have improved survival with intrathecal devices, in that they have less refractory cancer pain, they have better quality of life with this, and their survival has been shown to be greater with these patients. So my take-home message is there's an urgent need to develop individualized strategies for preventing and treatment persistent pain in cancer survivors. There has to be care taken to the types of drugs that we use due for the type of tumor, type of cancer the patient has, whether or not this pain is due to the tumor involvement itself or due to the treatment that we use. And so we need to develop pain treatment strategies that will not only relieve the pain, but it won't increase the cancer progression and mortality in the patient, and it would be ideal for patient care. Any questions?
Thank you. Questions?
Yeah, that's great. I'm wondering, now that you're facing the intrathecal catheters, and it's fantastic, when would you select a multiplexus block or plexus block even, block even, block even, block even,